see people trickling in, so we're just going to wait a second. Great. Well, good day, everybody, and welcome to our session today. My name is Scott Weiner. I'm the director of the program in opioid and pain innovation at Brigham and Women's Hospital. And we're delighted to co-sponsor this event with the Harvard Medical School Center for Global Health Delivery. Welcome to the third iteration in our series, which is entitled OUD Around the Globe, in which we're learning from countries around the world regarding how they are managing the opioid overdose crisis, focusing on policies and innovative solutions that we can all learn from. Because really the best way to learn is from each other. And the fact that we can share each other's experiences might be the solution to this issue. For our first session a couple of weeks ago, we were focused on North America. We had speakers from Canada and the USA. Last week, we had a very interesting session from the UAE and Germany. And this time we're moving further east to Malaysia and to Australia. And one of the inevitable facts about our globe is the existence of time zones. And so thank you for shifting this conference 4 hours earlier than our usual time to accommodate our speakers today, where it's 8 o'clock, I think, in Malaysia, and it's 10 o'clock at night in Australia. So we're delighted that they have delayed their probably dinner and bedtime to join us today. So next week we will resume at the usual time at 12 p.m. Eastern, and then we'll have a session next week and the final week. And just a reminder that we are recording all these sessions, and we will be writing up conference proceedings as well that we'll be happy to share with everybody when they're done. I have the honor of introducing our speakers today as Dr. Vickna and Dr. Dietze. I'll start with Dr. Dietze. He is the Program Director of Behaviors and Health Risks at the Burnet Institute in Australia. Professor Dietze is one of Australia's leading alcohol and other drug epidemiologists with a significant national and international profile. He has an extensive history of innovative research into the impact of alcohol and other drugs in the community. He is also the recipient of numerous awards and prizes and is currently supported by a National Health and Medical Research Council Senior Research Fellowship. We are absolutely delighted to have you here and share your insights and experience. And our second speaker will be Dr. Vickna. He is the director of the Center for Drug Research at the Universiti Sains Malaysia. His research is focused on understanding and developing behavioral interventions for people who use drugs. Currently, he is a Malaysian principal investigator on a nationwide 5-year study entitled Implementation of Seek, Test, Treat, and Retain Strategies Among People Who Inject Drugs in Malaysia, funded by the NIH in the US. In fact, of his numerous accolades, I was struck by the fact that he was awarded from the National Institute of Drug Abuse the Excellence in International Collaborative Research Award. And it just shows the spirit of collaboration globally, which is perfect to have you here as well with us today. So to start, we'll turn it over to Dr. Dietze, and you have the floor.
Great, thanks. Okay, hopefully that's working and you can hear me.
We can hear you. I don't see any screen share yet. I don't know if you want to do that.
Yeah, I'm trying to. It should be working. All right. Trying again.
Yes. The world of Zoom.
Yeah. Okay, great. Thanks very much for inviting me and such a wonderful introduction, and it's great to be a part of this series. I'm speaking to you from Wurundjeri land, which is land that's never been ceded. So the Wurundjeri people of the Kulin Nation are the traditional owners of where I'm privileged to speak from. This is literally 50 metres from my front door. This is a creek in the middle of Melbourne, and I'd like to pay my respects to elders past, present and emerging. So just before I begin, a couple of disclosures. So I've received some investigator-driven funding from Gilead for work related to hepatitis C treatment, and an untied educational grant from Indivior for work related to buprenorphine and naloxone, and I've been an unpaid member of the NED board for intranasal naloxone. So just in terms of the themes of today's talk, it's along the lines of what I was asked to talk about. So literally to talk about the burden of opioid use disorder in Australia, some of the epidemiology and impact, some of our interventions and the solutions that we've offered, and give you some insight into successes and failures in that regard as well. So I'll kick off by just giving you a map of Australia. Australia is basically the same size as the 48 contiguous US states, but we have a dramatically smaller population. And the population is largely concentrated in a series of cities around the perimeter of the country. And the two biggest cities, Sydney and Melbourne, constitute about 40% of the Australian population, with about 5 million in each of those two cities. And there are dramatically different patterns of drug use and drug-related harm across the country. So heroin use and sort of illicit opioid use is really confined largely to Sydney and Melbourne these days, whereas methamphetamine and prescription opioids are what's used in other parts of the country more so than in Melbourne and Sydney, although we do have those substances used as well. So the basic message is we had a really big heroin crisis back in the late 1990s that some of us turned the heroin glut in Australia. And then we had a sharp fall in heroin-related deaths that happened for reasons that are pretty difficult to explain. Some people attributed it to some successes in law enforcement in late 2000, early 2001. But really, there was no coherent explanation for what actually occurred. But there was this dramatic change, and but still, it is worth pointing out this rate of 6 per 100,000 is still dramatically less than, say, what's been observed in Vancouver or in much of North America. But we have seen this bubbling along of opioid-related fatalities coming back up to levels that we haven't seen since the mid-1990s. And you get a picture of the other sorts of rates of drug-related deaths there. And most of that is being driven these days by pharmaceutical opioids rather than heroin and other illicit opioids. But you can see that over this period here in the orange, there has been an increase in illicit opioid-related deaths, so heroin-related deaths, but still not at the level that we saw in the late 1990s. Irrespective, the characteristics of these deaths have remained largely stable. So around about 70% of them are male, 53% involved in injecting drug use, and about 2/3 of people are aged over 35 years. We see similar sorts of patterns in relation to non-fatal outcomes like ambulance attendances. So we've established a very comprehensive ambulance attendance database that has allowed us to chart the last 20 odd years patterns of opioid-related harms appearing in ambulance, ED presentations and so forth. And you can see heroin incidence basically has been increasing over recent times. Other opioids have really started to tail off a little. But still, as I said, the rates here are still dramatically less than they were back in the late 1990s. We have a national drug strategy which applies what is termed harm minimisation. And the nuance of using the term harm minimisation versus harm reduction and so forth is often lost on people from outside of Australia. But essentially, we cast harm minimisation as the overall strategy, and we purport to have a balanced approach across 3 pillars. So demand reduction, which is essentially treatment related initiatives and so forth, supply reduction, which is essentially law enforcement, and then harm reduction, which is assisting people who do use substances to use them as safely as possible. We've had this strategy in place essentially largely unchanged since about 1985. But there are constant upgrades and reiterations of it. But we haven't had a national overdose strategy since the end of the heroin glut in 2001, which is kind of a pretty significant indictment on our policy frameworks, given that we did have this sophisticated way of framing our policy responses prior to that. So what sort of overdose prevention initiatives do we have? I mean, that's my main focus. That's where I sit mostly, rather than kind of in a treatment frame. So we do have a comprehensive opioid agonist therapy treatment system. So largely based around methadone and buprenorphine naloxone. We don't have injectable opioid agonist treatment like heroin prescription or hydromorphone. We did actively explore this option in the early 1990s, but for various political reasons that wasn't pursued at the time. We don't have a widespread antagonist treatment option. So we do have oral naltrexone, but we don't have implantable available. We've got a very comprehensive first responder system, so paramedics and fire brigade, they provide direct response to overdose, so they're equipped with various mechanisms of breathing people and so forth. We have discretionary law enforcement in place, so police aren't required to bust people for possession when there's some kind of intervention for an overdose. Sorry. Yep. Okay. Keep going. We have various forms of peer-led education. So overdose recognition and response is something that we've been educating people who inject drugs in particular for an awful long time. We now have take-home naloxone, and I'll come to describe that in some more detail in a little while. We have a couple of supervised injecting facilities, which I'll also walk through briefly. We also have a very extensive primary care system for key populations, such as sex workers and people who inject drugs. So we have specific primary care centres set aside for those key populations. And the overall context is that we do have universal health care. We do, as I said, have harm reduction and harm reduction for bloodborne viral infections in particular. So we're one of the world success stories in relation to HIV prevention. Our extensive needle and syringe program has prevented an HIV outbreak amongst people who inject drugs. And we also have freely available hepatitis C treatment for people who continue to be active injectors. So some of those things are a major innovation. But I'll talk largely about overdose prevention initiatives. So take-home naloxone was actually first mooted in Melbourne, Australia in 1992. And apparently, according to John Strang, that was the first time that anyone had ever mentioned this kind of initiative. But we've had this long history of waiting. We did this feasibility study in 1999 or in 2000 that were linked to some of the pioneering work in Berlin and Jersey and also in Chicago. But that work concluded that a national trial was needed. And then, as I said, we had this end of this heroin glut. And so we actually lost a lot of focus on drug-related death. Essentially, the massive decline made us think, oh, well, that's basically finished. And we didn't really pursue a lot of the prevention initiatives that we needed to do. And of course, there's still hundreds of people dying, just not in the same numbers. Now, we did focus a lot on developing intranasal naloxone, so we did a lot of work around that. So we led the original head-to-head trials of intranasal versus intramuscular, for example, that were published and had a bit of an impact even in places like the US too. But in 2009, there was a couple of publications in some of our scientific journals that called for increased access to naloxone for peer administration, and we concluded that a controlled trial wasn't necessary anymore. Basically, we just called for a rolling out of it and a whole range of supporting legislation around it too. And I was lucky enough to be involved in the first program in the ACT, the Australian Capital Territory, which is a bit like Washington, DC. It's Canberra is the actual name of the capital city in the Australian Capital Territory. And through this pilot program, we trained over 200 participants, and including inmates of the prison, and reversals were reported. All were successful. There was no adverse events or anything like that. We showed that the training resulted in high levels of knowledge in the management of overdose. The program had a positive impact for participants, and really what you would expect is that there'd be a major rollout of this kind of intervention when you've got such positive results. This is what the picture looks like across Australia at the moment. It's a complicated graphic, and if you wanted to follow up, it's available at this website here for the Centre for Research excellence into injecting drug use. But basically we have, these are the Australian states and territories. 3 of them are involved in a Commonwealth-funded pilot whereby any form of naloxone, whether it be intranasal or intramuscular for peer distribution, is available over the counter for free from a range of different locations as well. And peer naloxone training is available in most jurisdictions. There's some online training available. Proper Good Samaritan protections for those who are intoxicated is available in the ACT. The Good Samaritan legislation is much less clear elsewhere. And so we have this, it's pretty piecemeal at the moment in reality, except this investment that's gone into this federal government pilot, which is running its course and should have its results published soon. That's the biggest investment we've had. That's some 10 million Australian dollars, which is a substantial amount of drug purchase and so forth. So that's, as I said, pretty piecemeal. We have that Commonwealth pilot. We have intranasal naloxone finally. So as I said, we actually did the original trials on comparing intranasal to intramuscular, and it took us a long time to actually approve intranasal. But we don't have consistent legislation. As I said, Good Samaritan provisions are variable, and in one state and one territory in particular, you can be prosecuted if you do administer any kind of first aid and you're intoxicated and it doesn't go according to plan if something went wrong. There's no national coordination of any description. We don't actually know what the targets are that we should be trying to reach. That contrasts with something like hepatitis C, for example. We don't have standardised access, such as through emergency departments and so forth. Even some ambulances don't carry naloxone in some rural parts of some of the states, not in the bigger states like Victoria and New South Wales, which is in the southeastern corner where I come from. We have very limited point of custodial release distribution except in New South Wales, and that's a big gap given that we know that that's a very high risk period. And there's no consistent programs for pharmacists or primary care, and that's, as I said, that is changing. So that's where we are in relation to naloxone, but taking a look at medically supervised injecting rooms. So basically, I'm sure most of you will be aware of what these facilities are, but they are aimed at street-based or public injecting drug use. They're indoor, legally sanctioned facilities where supervision of injections is undertaken by trained staff in relatively clean conditions. And basically, people can use drugs procured from elsewhere. And the one in Sydney that was opened in 2001 was the first in the English-speaking world. It was just before the Insight facility in Vancouver. This is the Sydney facility, what it looks like. It's basically a pretty innocuous shop front in a notorious kind of red light district, although it's been very gentrified recently. But you go inside the facility and this is the reception counter. Reception counter, you walk up some stairs and there's a basic sort of hand hygiene area. You move over to the booths where the injections are supervised and can take place. They're relatively clean, with obviously disposal containers and advice on how to inject. This is the recovery room needed if someone experiences an overdose or anything like that. And this is a recovery room for people to just chill out before they actually leave the facility. And then once they leave the facility, they essentially go into a back street behind that main thoroughfare in King's Cross. So that's what the facility actually looks like. And there's a substantial evaluation undertaken that showed all of these effects, reductions in ambulance fallouts, deaths, clearly cost effective, and a reduction in public injecting, so improved amenity for the area as well. But we only have one medically supervised injecting centre in Sydney. For years, it was just given this trial status, a bit like the one in Vancouver as well. And part of the reason why I think the focus was lost is that the heroin glut ended, And the idea of there being an emergency dissipated as well. And there was also a sustained campaign against the facility in tabloid newspapers. But I'd also argue that there was poor planning. So again, we're in this situation where we have these really positive findings about an initiative, and then we don't actually go ahead and roll that initiative out. And part of that was connected to changes in government. Now, Melbourne, the city where I'm based, we actually had a similar plan for the implementation of injecting facilities. We proposed to have 5 of them established in 1999. But in spite of those plans, and in spite of the success in Sydney, it took us till 2018 to finally open one in Melbourne. And it came 16 months after a coroner's recommendation that such a thing be established. It's in a suburb of Melbourne called North Richmond, and I'll show you the pictures of it. So this is the community health centre in which it was originally housed. It's basically in the vicinity of the largest public housing estate in the Southern Hemisphere, in Australia. And it basically opened in this room here to begin with, and then they designed a purpose-built facility with lots of, so here's the injecting booths here, but there's lots of other scope for other healthcare provision in this site that they purposely built. And this is what it looks like here on the edge of the community health centre there. And so it's a very flash new facility that's operating there now. And this is what the injecting booths look like, and very similar to what you would have seen elsewhere in the one in Sydney that I mentioned before. It's incredibly well utilised. So basically, since opening in the small facility, they're getting up to around about 200 injections per day on average. And then when the new facility opened, getting up to around 330, making it the busiest site of its type in the world. Roughly equivalent to the Insight facility in Vancouver. And it's attracting the most vulnerable people, basically. So we've just had a paper accepted in ANJ Preventive Medicine, and in the paper we highlight how people who use it frequently are the ones who are most vulnerable. So the people who are unemployed, people who are homeless, living alone, and so forth. People who identify as First Nations Australians, people engaged in public injecting, and people who've been incarcerated in the previous year. So really, importantly, we're attracting the most vulnerable people into the facility. We're also showing big impacts on ambulance attendances. So not surprisingly, if you take those injections and have them supervised in the facility, then the number of overdoses attended by ambulance goes down for people who use it frequently, whereas people who don't use it frequently or haven't visited it, they don't have that significant impact. And that is statistically significant, that figure there. And similarly, we find these ecological effects. So the number of ambulance attendances more broadly in the Melbourne metropolitan area within 1 kilometre of the facility have gone down more than in the rest of Melbourne. So these kinds of positive impacts that you would expect of these types of facilities. So one of the big impacts of the Melbourne facility and its success is the idea of opening a second one. And it's proving to be incredibly controversial in spite of the fact that it's being proposed to open it in an area where there's already a lot of injecting drug use going on. And the facility they want to build is right here. And this alleyway that I mentioned here is already a tourist attraction, and it sits here, and it's literally 100 metres away or so. And this is causing huge controversy about putting a facility like this in the middle of Melbourne. So I'm aware of the time, and I'd like to wrap up quickly. So we're really aware that we don't have all the problems solved. So we really need to upscale all of our overdose prevention initiatives, and we really need to be focusing more on people who are at home and use alone, and people who don't inject substances, because we've kind of covered off mostly people who do inject drugs. So there's a range of other initiatives underway. We are exploring actively decriminalisation of small amounts of substances for personal use. Other areas of the country are looking at supervised injecting rooms, and so on. So on that, I'll quickly finish on the note that we really do need more national leadership, including a national overdose strategy, and we need some improved and new interventions. Thanks very much for listening.
Thank you, Dr. Dietze. Very fascinating, and I have so many questions to ask for the end of the talk. And just a reminder that we will be doing Q&A at the end, so please do have questions. You can put them in the Q&A box in the chat box now if you'd like, and then we'll address them at the end if there's time. And now I'd like to turn it over to Dr. Vickna, who's joining us from Malaysia.
Thank you, Dr. Weiner. Let me just pull the screen.
Great, perfect.
Can you see the screen?
Yes, we can. It's not presenter view yet, but yes, there you go.
Okay.
Perfect.
Okay, thank you for the invitation to present today. And yeah, I'll be presenting on opioid use disorder in Malaysia. Malaysia is based in Southeast Asia, the population relatively small country with 32 million people. Islam being the largest and official religion of the country. Major heroin problem, being close to the Golden Triangle, we had a major heroin problem in the 70s and 80s, right up to the 90s. And since the early 2000s, we've had a problem with amphetamine type stimulants. Before the heroin epidemics in Malaysia in the 70s, there was the opium epidemic, and then in the 70s, heroin became the most prevalent drug used, and more like I said earlier, most recently in the 2000s, amphetamine type stimulants have become very popular, and Malaysia's policy, drug policy, has always been based on a prohibitionist approach. Treatment and rehabilitation approaches for people who use drugs were limited to abstinence-based institutional programs, mostly penitentiary-based. And Malaysia is not alone in this. I think it was very common in Southeast Asia. Countries like Vietnam, China had very similar prohibitionist approach where drug use was illegal. People who are suspected of being drug users can be detained, tested randomly for illicit drug use. Doctors were not allowed to provide treatment and were required by law to report people who use drugs to the enforcement agencies. However, in the early 2000s, Malaysia, the Millennium Development Goal report by the United Nations highlighted that one of in the report that Malaysia was unable to reverse its HIV trends, and this prompted the Malaysian government to then start looking or introducing medical interventions or medical treatments to reverse the high infection rates that was occurring among people who injected drugs in the country. And this is a series of surveys that we conducted with people who use drugs several years ago. It's an older slide, but I like to use this slide because it clearly shows from these surveys of drug users when the onset of heroin and ATS use in the country. And you can see that, ATS from the beginning of the millennium started to spike, whereas heroin was always there, and then it went down for a while, but heroin has always been around in that sense. In terms of, so like I said earlier, it was largely prohibitionist approach, which it's still to a large extent based on a prohibitionist approach, the Malaysian drug policy, but medications were introduced in the early 2000s to reverse the trend of HIV infections in the country. And medication-assisted treatments were started in the early 2000s. Buprenorphine was approved in 2002, followed by methadone, and needle syringe exchange followed after that in 2006. So in the last 20 years or so, you can see that buprenorphine, we have about 380 general medical practice officers who offer this treatment to about 10,000 patients. They are not provided for free by the government hospitals, but they are provided by the private medical general practitioners. So patients have to pay for these medications, whereas methadone is provided for free by the government as well as by private medical practitioners. And there are about 100,000 patients right now in about 800 to 500 government and close to 400 general practitioner clinics. So it's methadone is widely and easily available in both government as well as private general practice. Needle exchange started in 2006. We have currently about 20,000 people who are on needle exchange program, and there's been a policy now, or an informal policy actually, to try to shift needle exchange patients or needle syringe patients to start to get into methadone programs. So I mentioned earlier about institutional incarceration, where we used to have this. They're still available. There are still 23 of these institutions where drug users are mandated, can be sent by the courts to undergo a 2-year drug institutional treatment programs, and currently there are about 23 of them in the country. And there was a study conducted by my colleagues in KL, and they looked at the incarceration-based rehabilitation, the outcomes from incarceration-based rehabilitation in Malaysia. There are also other publications around the world that show how the poor outcomes of incarceration-based rehabilitation or treatment programs in Malaysia. In these institutions, there are no medications that are offered. They're just purely psychosocial intervention, and the older understanding of drug use was a social problem and a security threat. Therefore, they had to be disciplined and so on. So if you look at time to relapse, and this is a study done in comparison with compulsory participants that were in compulsory drug detention centers versus those who underwent voluntary drug treatment centers. And you can see the difference is a stark difference of, people undergoing this compulsory treatment for 2 years, and they relapse within a month of being released, compared to those in voluntary drug treatment center participants who were almost didn't relapse for about a year. And voluntary-based participants had an 81% decreased chance of opioid relapse compared to compulsory participants. The current drug use practices in the country, most heroin users use multiple substances. Polydrug users, for example, heroin is frequently used with benzodiazepines as well as ATS. We do not routinely collect heroin or opioid overdose data. Most of the heroin that's used are illegal heroins. We don't have prescription opioid, high amount of prescription opioid abuse in the country. In the course of our work over the years, we rarely see actually fatal heroin overdoses in the country, and this could be explained by the street heroin purity, which has decreased substantially from 30 to 50% in the 1980s to only about 3 to 5% lately. And this low street heroin purity has led to, or may have led to, increase in drug injecting practices. We also see from our discussions and work with drug users, we find that people tend to start inhaling heroin and they convert to injecting heroin at a much shorter period of time compared to heroin users many years ago. And this large could be attributed to the low heroin purity that's available in the streets. I would like to talk about 3 main laws that concerns people who use drugs in the country, and I'll show you some data about how these laws are being used and to further incarcerate people who use drugs in the country. The 3 laws. The first law is Drug Dependence Treatment and Rehabilitation Act 1983. This is when a person who's can be stopped by an enforcement agency who reasonably suspects someone to be a drug dependent can be detained, and they will be evaluated by a government medical officer and a certified government medical officer to determine dependence, to determine substance use dependence. And based on that, they can be the court, the criminal justice system can send them to a rehabilitation center. This is what I was talking earlier about the institutional rehabilitation centers for 2 years, or can be provided with a community supervision. So they go to a rehabilitation center for 2 years. This is followed by another 2 years of community supervision, or they can receive community supervision by the National Anti-Drug Agency for a period of 2 to 3 years. So these are the two options available for those who are charged under this section. So this is Drug Dependence Treatment and Rehabilitation Act 1983. The second act is the section 15(1) of the Dangerous Drug Act. So you notice that in this act, the word treatment and rehabilitation is not there. Under this act, consuming, taking, or self-administering any drugs can be punishable by a fine not exceeding 5,000 ringgit and imprisonment not for about 2 years. So this does not, the difference between section 3(1) and section 15(1) is under this section, the enforcement agency does not have to produce the individual before a medical officer to be certified as a drug dependent. All they need to do is to provide a positive urine, and this would then classify them as consuming, taking, or self-administering any dangerous drug. And this would immediately allow them to be imprisoned or with a fine as well. But most of them do end up in the prison as well because they are unable to pay the fine. So and then the third law, which recently enforcement agencies have started using, is section 39C of the Dangerous Drug Act. You see for section 15(1) and section 39C, it's under the Dangerous Drug Act, different compared to the section 3(1), which the word treatment and rehabilitation, where a medical officer have to certify drug dependence. So section 39C is a net deepening move by the enforcement agencies to increase penalties for people who have been previously charged under section, people who have been charged under section 15(1). So those who have been charged under section 15(1), who have been convicted previously or had 2 previous admissions or conviction under this section, can be now sent to prison for anything between 5 to 7 years with whipping as well. So the imprisonment has increased, and this net deepening move. I'll show you data now. If you look at over the last 6 years, from 2015 to 2020, this is something that we just recently published in the International Journal of Drug Policy. If you look at for section 6(1), on an average, there's only between 8 to 10,000 people that have been sent for treatment and rehabilitation. Those who have been detained under this section, sent to these institutions, or sent for community supervision, have been ranging between 8 to 10,000 people over the last 6 years. But if you look at section 15(1), the number of arrests by the enforcement agencies has been ranging has been actually hovering around 70 to 80,000. Last year there was a dip, probably because of COVID, but you can see it's almost an 8 times increase in the number of people that are being arrested and sent to prisons without being offered treatment, or where without dependence have been established. Dependence is not being established by a medical professional, but they have been sent to prison, and this is a criminal offense, whereas the Section 6(1) is not a criminal offense. So you can see a very high number of people who are being recently being detained and sent to prison over the last several years. And if you look at the what I said, the net deepening move by enforcement agencies over the last 4 years from 2006, you can see previously they did not use much of this law to send people to enhance prison sentences for those who have relapsed under Section 15(1). But over the last 3 years or so, from 2017 to 2019, you can see there's an exponential increase. You know, if you look at it from 2016 to 2019, there's almost like a six-fold increase in the number of people that have been charged and sentenced to this enhanced prison sentence under Section 39C. So this is something that we people like us who are working in this area have been advocating with the government to relook at this high number of people that are being sent to prison for using drugs. This is not for drug trafficking, but purely for using drugs. And this is data that I've got from the Malaysian HIV/AIDS Progress Report. It shows high coverage of opioid use disorder medication, mostly methadone, increasing from 30% to almost 90% for among people who inject drugs, not necessarily for only for people who use drugs, but this is specifically for people who inject drugs. The coverage seems to be high among this population. HIV related data for on key populations. We've got female sex workers, male sex work, men who have sex with men, people who inject drugs, and transgender. We just focus a bit on the people who inject drugs column. This is an estimate by the Ministry of Health. They've done a size estimation among key populations and the biobehavioral surveys that they've conducted. So there's an estimated 75,000 people who inject drugs in the country. HIV prevalence is 13.5%. Before the year 2000, people who inject drugs were the main drivers of the HIV epidemic in the country. There was about 80%. With the introduction of medications as well as needles, HIV prevalence among this group of people have dropped significantly now to 13.5%. Slightly more than 1/3 know their HIV status. ART participation is still relatively low among this group of people. This is the study that I'm currently doing in the country, is to see how we can get more people to be tested and treated, or to enroll in ART participation, ART programs, treatment programs. Condom use during last sex, only a quarter of them reported to use condom during the last sex. In conclusions, can look at, I talked about the laws earlier. Existing law concerning people who use drugs in Malaysia are not aligned with current medical conceptualization. The dangerous drug law is 1952. The laws need to be relooked or revised. They need to take into consideration the advancement in the medical fraternity, in understanding what substance use disorder is all about. So I think a mere urine sample or urine positive is not sufficient to determine a person's substance use. I think it has to go beyond that. And I think, yeah, and the high numbers of people who are being detained, people who use drugs who are being detained rather than offered voluntary treatment. And this would, we can see, I showed you earlier the ineffectiveness of institutional programs and imprisonment as well. So sending people to prisons is not going to help the situation. Costly and ineffective detention-based institutional rehabilitation programs should be replaced with evidence-based and voluntary treatment programs. In addition to it being ineffective, it's also very costly. For example, we have also done some cost estimations. it costs about $15 to keep a person in prison in a day, whereas the cost of providing methadone is $1 per day, or even less than $1 per day. So the cost is much cheaper. It's far more effective. So we really need to start shifting towards more treatment-based programs. Further expansion of medication-assisted treatments are needed, especially we provide methadone, but those people who use drugs who are using heroin together with amphetamines, treatment, psychosocial interventions, for example, can be strengthened to improve treatment outcomes among methadone patients. HIV testing among this population is also low, and barriers to ART participations among people who use drugs with HIV need to be eliminated to significantly increase their participation rates among people who use drugs in Malaysia. We find that there's still significant barriers that are, institutional barriers, systemic kind of barriers that are still in place. For example, physicians being reluctant to enroll people who use drugs on ART, even clinics within the health system, where infectious disease clinics and psychiatric clinics there needs to be, better coordinated to get patients to enroll in their program. Right. Thank you.
Great, thank you, Dr. Vickna. And we welcome Dr. Dietze back as well, if you'd like to join. Well, very interesting presentations, and just interesting to hear the different approaches regarding safe injection facilities, law enforcement in particular, and how that intersects with the treatment of people that are suffering from opioid use disorders and other substances as well. It's really amazing how these various policies and laws in different countries really do shape how we treat patients that are suffering from this. So thank you for sharing that information. We have about 12 minutes for discussion, and I encourage everyone to ask questions in the Q&A and chat box, and I'll get to those in a second. But I do have a couple questions to start. And the first is actually, in North America, we've been really suffering from fentanyl. And there was a transition from prescription opioid use to heroin to now fentanyl. And it's an issue of supply chain is what we're told. And particularly, Dr. Vickna, you mentioned about the cutting of heroin in your country, about how it's like 3 to 5% potency of what it was before. Now with this concentrations of fentanyl being so high, we're seeing a lot of people using that in at least in North America, and the rates of deaths are just increasing markedly. Do you have a sense of why that hasn't infiltrated into Australia or Malaysia, particularly given just the supply chain and how that plays into what drugs people are using?
So I'll jump in here. So we keep expecting it to hit because there's kind of no real reason, given that it's so easy to ship, there's no real reason why it wouldn't be expected to come into Australia, but we just haven't seen illicit fentanyl on the streets at all. What we do see is occasionally diverted pharmaceutical fentanyl, and so that does feature quite prominently in, say, our opioid-related deaths, but it just hasn't come into the country. Our customs services and officials can't be that much more efficient than the US and Canadian ones. So it really is a puzzle. And whenever we do see anything like that coming onto the street, where there's big alerts and big warnings given and so forth to people who use drugs, but it just doesn't seem to sustain. So it's very odd, and the police really don't have an adequate explanation either.
Interesting.
In Malaysia as well, we have not seen fentanyl in the country. We have not heard of any reports nor any seizures of fentanyl, and I'm not sure. I'm not sure why it's not coming. Fortunately, it has not. But maybe America is a much bigger market and a much lucrative market for fentanyl to be brought in.
Oh, interesting. Although it sounds like stimulants are now an issue, and we're starting to see that as well. One of the challenges with stimulants, different than opioids, is that there's not an analogous medication for addiction treatment. Obviously, buprenorphine or methadone. How have you dealt with treating the stimulant epidemic?
I think stimulants is just psychosocial interventions. Like you rightly said, there are no medications. And this we see has begun to also impact methadone outcomes, methadone treatment outcomes, because participants or patients who've been using methadone and have been rather stable over the last several years, when they start using amphetamines, then treatment outcomes becomes poor again. So this is something that needs to be strengthened, or capacity needs to be developed in the country to, I think many of our methadone treatment programs emphasize just the medication aspect, whereas the psychosocial aspect is lacking. And with ATS being used widely now in the country, this component of interventions need to be strengthened.
Yeah. There was a question for Dr. Dietze. What is the rate of overdose in these Australian injection facilities?
Yeah, so I haven't actually seen it calculated recently, but I did some quick back of the envelope. And so the Melbourne facility, when it opened, has in its first 18 months, there was some 120,000 injections and around about 2,700 opioid overdoses, which translates into about 2.2% of overdoses per injection. Oh, so 2.2% of injections, result in an overdose. Obviously, that's multiple people presenting over those 119,000 injections. So some people will experience an overdose and others won't. Of those overdoses, though, only 10% involved the administration of naloxone, because the beauty of having a injecting facility is that if someone does overdose, you can basically just support their breathing for a few minutes just to make sure that they don't actually need that. They can be revived and resuscitated without naloxone, because it's more pleasant for them if they are. And so, as a consequence, an injection facility is the ideal place to have an overdose in. So, yeah, we estimate probably around 2% of injections result in some kind of overdose, and around 0.2% of injections result in naloxone administration.
Yeah, interesting. And there's another question from Dr. Chowdhury that it's kind of similar to what I was thinking also. And I don't know if this is an appropriate framework, but it seems to me that there's kind of a spectrum that societies go through. And the first is the idea of treating patients that have opioid use disorder, things like methadone and buprenorphine. And then the second is actually provision of Narcan, which some people viewed previously as permissive, allowing people to use drugs, but now is becoming accepted because it saves lives, to then actually providing the safe injection equipment, right? The needles and the syringes, next to actually allowing them to inject in a legal, safe space. And then there seems to be kind of a final step, which we heard about in Canada, where they're actually providing full opioid agonists like hydromorphone. And it seems to me that the progression follows data, right? The more we learn about it, the more we learn about safety of these different steps, the more societies are more willing to accept this. So actually the question that was asked Dr. Vickna is, how has the generation and presentation of this scientific evidence been helpful in moving the needle with regards to the governmental policies and laws?
Yes, I think there's a group of us who continue to, my colleagues who do work in the same area, we have continuously advocated the government on relooking and shifting the Malaysian drug policy. But it is always a challenge when we do this, when we present scientific data to the enforcement agencies. I suppose we're all wired in different ways. Enforcement agencies they look at things from a different way, but it is a continuous effort. I don't think we can do this in a short period of time. There has been continuous efforts to advocated this with various stakeholders from policymakers right up to going to the Malaysian Parliament and presenting to parliamentarians because they can change the law, advocating a shift in drug policy. So there are several and many efforts that we've done in the past. I think it's a continuous effort that it's small building blocks that needs to take place. I think if we look back and learn from experience of how Malaysia shifted, introduced medications and needles in the early 2000s was because of the HIV epidemic, and so at that time, there was an urgency for the government to actually change or introduce medications and relook at its drug. But they didn't change the laws. While they brought medications in and they introduced needles, the laws that were there since the 1950s continue to be there, and therefore enforcement agencies can easily use these laws to enforce. And I think I'll give you a bit of a very quick background of why this has happened. Is because during the heroin epidemics, medical practitioners were willing to certify dependents because they could easily observe opioid withdrawal symptoms, whereas when amphetamines were beginning to be used, healthcare professionals who are not specially trained in addiction were unable to physically observe dependence because amphetamines having psychological dependence. Hence, they were unable to certify dependence, and therefore enforcement agencies started using the other laws to then incarcerate them. So this is kind of a background of why this different use of laws took place in the country.
Very interesting. Yeah, Dr. Dietze, please.
I might just jump in quickly. So, policy doesn't develop in a vacuum. It doesn't develop linearly. We had the experience, as I said in my talk, that in 1985, a national drug strategy was developed, and that really came from our Prime Minister down, because his daughter, it was revealed, had a heroin issue, and he came out on television saying that and was in tears, all of this kind of thing. And that led to the humanisation of the whole issue from the outset, which then underpinned a public health approach to drugs, which has really been Australia's position for a long time. But what you would hope under that public health approach would be this linear progression, but it hasn't worked like that at all. As I said, we had a successful Sydney medically supervised injecting centre, and it took 17 years for the next one to be established. Similarly, take-home naloxone, John Strang first talked about it here in Melbourne in 1992, didn't get it started till 2012. So, even with progressive, sensible policy, there's lumps along the way, I guess.
And actually, I just wanted to ask a final question. And it's okay if you don't know the answer. This is for Dr. Dietze also, but I was very curious that Sydney had approved a safe injection facility much earlier than Melbourne did. And you've got a unique experience where there's actually just kind of two large cities. Did you see a difference in overdose deaths over time in those two cities, given that one had an injection facility and one didn't?
No, and I mean, I guess the problem, and this is one of the huge problems of the policy approach we've taken, is that this idea that this one injecting room can cover a population of 5 million is ludicrous. And you need to have more than one facility. And what we've seen in Vancouver, Canada, for example, is exactly what you would expect. Is if you've got an overdose crisis, you absolutely need more than one facility to accommodate all of the people who are going to be at risk.
Great. Well, thank you so much to our speakers. We're at time. I think it's probably past bedtime for some of our speakers and time for some of the rest of us to start our day. Very fascinating, so helpful to hear your experiences, and as we all work together to help solve this issue. Thank you to everyone that attended this morning. You can see in the chat, Sue had put the registration for the next session, which will be at 12 o'clock Eastern time next Tuesday. We'll be doing 2 more sessions, and it's just been so informative, and I'm just so appreciative of your participation today. So thank you so much to our speakers.
Thank you.
Thank you for the invite.
Have a wonderful day.
Bye-bye.
Bye.
Sue?
Hey, hold on, let me stop recording.